Hi, everybody, and thank you for joining us for Menopause 201. As many of you have been here before, you know these sessions are really meant to be a discussion between two clinicians about more advanced topics in perimenopause and menopause treatment. I am so thrilled today to welcome Dr. Ghazaleh Moayedi, and I'm going to let her introduce herself.
Hello, everyone. Really happy to be here today. Dr. Moayedi, she, her pronouns. I'm based in Dallas. I've been with Genève actually 5 years this month. And I've been providing menopause care with them now in 20 states via telehealth. So really happy to be here. I'm also a complex family planning subspecialist, which really just crosses really nicely into menopause care. So really very excited to be here today.
Thank you so much. And, I tell people all the time, some of our best menopause providers are our complex family planning colleagues because you just have such a depth of hormone knowledge, which I think is so critical in having these conversations. So today's topic is really to talk about bioidenticals, compounding, so all these words that we hear both from patients and social media, pretty much everywhere. So I'm going to start by asking you a question. Um, how do you think this focus on bioidenticals came about?
Oh, huh. That I don't know how I think it came about, but I definitely think it's so hard to even know what people mean when they're saying bioidenticals because there isn't actually a standard definition for the term, and it can mean a lot of different things. So sometimes when people are asking about bioidenticals, they want something that's natural. And again, what does natural mean? Unclear as well. They might mean something that's compounded, so made in a compounding pharmacy, because there are maybe some beliefs that that might be safer or more individualized, and we can kind of talk about if that's true or not. They might mean that they want something that's plant derived, which I think is also an interesting thing, and we can chat about that too. But those three pieces, I think, sometimes are thought of together, and really, I think of those in the bucket of bioidentical as a marketing strategy. That it is really a way to market different kinds of medications or supplements or drugs to people under a guise of safety, being natural, being safer. When I chat with people about bioidentical, I really talk about bioidentical as something that is molecularly and chemically identical to a hormone created by the body. So that is what we really mean by bioidentical. Again, without there being a standard definition or an accepted definition. So,
well, it's not a medical term, right? It
exactly.
really came out of marketing. And I think in my mind, it really came out of the furor after the WHI was released, and women who really needed hormone were looking for a safer option, and people were more than happy to market to that, right?
Exactly. And so, when we're saying like natural, what does natural mean? Right? Conjugated equine estrogen is from horses. So I think that's natural.
Mm-hmm.
Um, so you could take horse urine and it be natural as a drug to
Yes.
some extent. Compounded, it could mean compounded, but that just means that a pharmacy that is not regulated by the FDA has made it rather than a pharmacy that is regulated by the FDA. And that can be safe or not be safe, but largely what happens is we're talking about differences in potency, quality control, and potentially efficacy.
Yeah, and
And
safety, because several of those compounding pharmacies have actually caused serious infections
serious harm,
with lack
yes.
of careful practice. I think the other thing I think about when people talk to me, I want the natural or plant-based hormones, and we've seen this on social media, right? We've seen companies that are selling their plant-based estrogen. tell me, estradiol is not plant-based, right?
Well, okay, so this is interesting, right? Let's go back to biochemistry, and I'm sorry to
Uh-huh.
take us there, or
No,
molecular
please.
biology,
That's the
right?
point of this.
Human steroid hormones are made from cholesterol. That is how they are created. I don't ask me any more questions than that. That's part of the stuff you get.
Yeah.
But largely, plants do not make cholesterol. So the idea that you could eat a yam and get estrogen is incorrect. But pretty much all human hormones are derived in a laboratory fashion from a yam or from a soy. So, can you eat a soy and get estrogen? No, because there's no cholesterol in those two plants. But can you, in a lab, create estradiol from yam or soy? Yes, that is true.
Yeah. And I tell my patients that the synthetic estradiol and micronized progesterone that we have currently available, whether it's FDA or compounded, because it's actually the same crystalline
Right.
hormone, is probably 5, 10 steps away from a yam. I mean, we started with a yam at some point, but
Right. There was a
we're
yam.
way beyond that. Like nobody's harvesting yams for this at this point.
Right. We say
So
plant derived, but it's not like they have a yam factory in the back.
no, no, they don't. And I think it's important to educate patients on this because they want the safest thing.
Mhm.
And for some reason in our culture, natural, plant-based has become the keywords for the safest thing.
Right.
When in reality, probably highly regulated hormone is probably the safest thing that you
Right.
can take.
Right. One where we know the potency and concentration that falls within certain guidelines, one that
Hmm.
then has been studied and peer reviewed at that potency and concentration, where we know the effects on different tissues in the body, um,
Hmm.
rather than potentially varying
Hmm.
potencies, concentrations, and really other inactive ingredients that you might not be aware of.
Yeah. I'm going to make you hormone geek out a little bit more.
Yeah.
Can you describe a little bit conjugated equine estrogens? What's in that? Because we talk about, I mean, it comes from horse urine, so it's natural. But
Right.
what is actually in that compound? What do
So
we know about it?
it is 4 estrogens that are created from essentially, I think there's 1 or 2 horse farms, right, that they
Hmm.
come from. We could get into the ethics or not ethics of it. I think there's some
Yeah.
controversy around it. That's fine. But they aren't human estrogens. They are specific to mares. They are collected from their urine while they're pregnant, correct?
Hmm.
And
Yep.
then, and then created into Premarin.
Yeah.
Um,
And there is estradiol in there.
okay, yes, there is estradiol.
So that one is human, but I think there's even like something they call E8. You know, I mean,
Right,
their estrogens our human bodies have never seen. And
right.
then
So
one more
I would,
geeky estrogen question.
yeah. Mhm.
Estetrol, which is
Yes.
making a lot of waves. We have it now in the Nextstellis formulation as a birth control, but it's being trialed for MHT. What is estetrol?
Okay, so I think it's kind of, let's get again back to the molecular chemistry, right? For human estrogens, estrone, it's got, I just actually heard a great presentation this weekend that summarized this. It's one, right? One
Hmm.
hydroxy group, estradiol, two, um, estrol, three. So tetrone, four hydroxy groups.
Yeah.
So it is primarily created in the by the fetal liver or by the placenta. So it is not circulating in people with ovaries in women throughout their lives. It is really only circulating during pregnancy. It is not very potent of an estrogen, so it doesn't have a large effect throughout the body, which does mean as we're thinking about estetrone E4 that it does need to be in higher concentrations potentially. And it also doesn't have the same potential cardiovascular effects, which can be good or bad. It likely has less, it seems like it has less of a risk on venous thromboembolism, but then conversely, doesn't seem to have a benefit on lipid profile or cardiovascular health in the ways that we see with estradiol.
Yeah, and I've heard that described that it tends to activate at the nuclear estrogen receptors much more than the cell wall ones, and that may be why at the liver it doesn't have as much effect.
Right. Right.
Yeah. Oh, interesting. Okay. Enough hormone geeking.
Okay, so we kind of talked about this already,
Hmm.
about how this real focus on bioidentical hormones came about. But we talked about the Women's Health Initiative, but what else do you
Hmm.
think as far as this focus on them?
Media. I mean,
Yeah.
I think the media and social media have been a huge driver and promoter. And, if I had to pinpoint one moment in time where this became a huge explanation problem for us OBGYNs, it was Suzanne Summers on Oprah Winfrey, talking about a person who isn't even a physician and their protocol for
Right.
going up and down and up and down and up and down with all different hormones that made her feel young and feminine forever. And don't even get me started down the feminine forever pathway because I think that is such a load of BS.
Right.
Um, but I really feel like it's just been promoted over and over again in social channels, mostly by people who are selling something.
Right.
And I think a really important point about that is they're selling compounds, right? And many of the people on this call will know we do not prescribe compound hormones at Genève. But have you used compound hormones? Do you use compound hormones? Why or why not?
Yeah. Well, I have myself used compounded pharmaceuticals, I guess. So,
Hmm.
sometimes you might need to prescribe like actually now that I use my joke name for it all the time, but I used
Hmm.
what I call donperidone, but the donperidone for breastfeeding. So
Right.
sometimes you might need to use a compounded medication if it's not available in the US, but I don't typically use compounded hormones in menopausal hormone therapy. And I'm going to give one asterisk and caveat. But why I don't, one, they can be hard to get. It's hard to know if your local compounding pharmacy is a good compounding pharmacy. And most important, they're not cheap and they're not covered by insurance. So oral estradiol is just incredibly cheap, even if you don't have insurance, which many of my patients don't have insurance. It can be affordable. Um, Transdermal patch, there are good deals even if you don't have insurance. Micronized progesterone, you can get fairly cheap even if you don't have insurance, and many insurances cover them completely or almost completely. So I've had patients that have been paying well over 100, 200, $300 a month for their compounded hormones that they've been getting from another provider, still not getting relief. They finally find us. I prescribe them medications that immediately provide relief and are 100% covered on their insurance. So this is a big reason that I don't prescribe compounded medications, is just around the cost and the health equity piece of them. Um, I'll give the one caveat is that micronized progesterone is suspended in peanut oil. So if people have a peanut allergy, and you can find a compounding pharmacy that will compound it, for example, in sunflower oil, that might be a good reason to seek out a compounding pharmacy. But
But
that's
you also need to be very careful with micronized progesterone because it's micronized for a
right,
reason. It's very hard to absorb.
right,
So you
exactly.
need to have good faith in that compounding pharmacy that they can correctly micronize it into that sunflower oil.
That they're actually going to get it. Because if
Right.
not, then, we're putting people in danger. So I've
Hmm.
yet, if anyone has one, they're using one that will ship across the country, but I have yet to find a good compounding pharmacy that I can rely on for that. But that is kind of the scenario where I might think about it. But otherwise, there's not much benefit to the patients I take care of. And putting aside safety risks, which are not nothing, also just cost risk or cost in general is a huge reason to avoid them. You can individualize and personalize hormone therapy without it being a compounded medication.
So I'm going to bring up a controversial topic that we can both talk about, which is, well, what about testosterone? And just a caveat, we do not prescribe testosterone via Genève because we're an entirely online pharmacy, and we feel that using a controlled substance deserves an in-person visit at least once a year. Um, But I know when I was starting out and trying to understand how best to use testosterone for hypoactive sexual desire disorder, that's where I use it because that's where we have some data for it.
Right.
Um, it's not easy to do. We don't have a female dosed product in the US, do we?
Right, exactly. So more often than not, when people are getting testosterone from other providers, it's a really high dose. And so what
Hmm.
do I see when they finally see me? I'm still not sleeping. My anxiety's still really high. I'm still losing my hair. My mood is still bad. And I'm like, yes, those are actually also all symptoms of testosterone at levels that are too high for you. And so
Yeah.
what I usually tell patients is I support anyone to use testosterone for the effects that testosterone gives, which is largely more male-like symptoms. And so if
Mhm.
that is what you are seeking, I support you in that. But typically for menopause treatment, that is not what we are looking for.
Right. And I've had people be told that testosterone will solve their hair loss when in
Right.
fact the opposite is true,
Very much
or remove their acne when the opposite is true.
opposite.
And I too have seen patients who are really in transition levels of testosterone. And I have to be very clear that
Right.
they're, at some point will transition at those doses. When I go to use testosterone, I learned from the International Society for the Study of Women's Sexual Health and the Menopause Society, both of which recommend using a test-in protocol or
Mhm.
androgel. So basically taking the male dosed product that's FDA regulated and available in the pharmacy and using it at 1/10 the dose. I find it easier with Testim because it does come in little tubes rather than the ketchup packets, which are just impossible. So I
Right.
have my patients get those tubes. I hand them a 5 cc syringe, have them empty the tube into the 5 cc syringe and dispense a half cc a day until they get the feel for what a half cc looks like. And then they can just use it straight out of the tubes. But each tube is meant to last 10 days. This is very actually cost effective, usually cheaper than compounding testosterone because a box of 30 tubes of Testim using a good RX coupon, because no woman actually has coverage for sexual
No.
function. And I mean, even if you have insurance, using a good RX coupon is usually less than $150. And that box of 30 tubes will last you 300 days.
I think what you said is so just that was such
Mhm.
great practical advice, but like the real key was it is a tenth of the dose that is
Hmm.
available. And
Right.
so when we see people that are getting pellet with another pellet, another pellet, and another pellet, and another pellet, and then when they see
Hmm.
it, and they're like, I just have racing thoughts and I have really bad anxiety all the time. And I'm like,
Yeah. And you have a beard.
yes, and your hair is going like this, right?
Yeah.
Um, oh, I had a like follow up for that and then I completely lost. Oh, do you find or do you use testosterone really first line when people are talking about low libido or libido issues, or what do you do? Because it's not what I use first line either.
No, it is not my first line. So that's a really good question because I think it it seems like a magic bullet.
Right.
And like all things sexual, female sexual function, there is no magic bullet. We differ in our physiology. We don't just need something to get it up, so to speak.
Right.
So what I do first is actually take a really good sexual history.
Yes.
What are
Yeah.
the factors contributing to sexual dysfunction? Is there pain?
Yeah.
Step one, fix the pain. Your
Pain.
brain is very intelligent. It does not want to do something that's painful. What sleep issues are you having? Because if you are chronically fatigued, when you see a bed, you're not thinking about sex.
No. No.
You're thinking about sleep. What social factors are contributing? What's your stress level? All of these
Mhm.
things are what I think Dr. Nagoski and Dr. Mintz, who are two of my favorite books, say are brakes. And I tell patients you have 1 foot to drive your car, and your
Yes.
car is sexual desire. It's either on the brake or the accelerator. And if it's on the brake, it can also be on the accelerator. You're just not going to feel like it. We need to take your foot off the brake and go back to the accelerator, and that takes work. So typically, I also start menopausal hormone therapy with
Right.
estrogen and progesterone if they're a good candidate and if they're not already on it, because there is some component of feeling good and feeling like yourself that goes into sexual function.
That's, I mean, it's funny that you say that because one of the analogies I use is that largely the on ramp to arousal for men is linear,
Mm-hmm.
And for men, and right, I'm using these gender terms generically, but for
Yeah.
women, it's like this
Yeah.
and this, right? And that
It's a maze.
right, and that also that you can't feel good until you feel good. So
Right.
we have to address the menopausal symptoms first
Mm-hmm.
before you have space for arousal and pleasure.
Right. And I think Dr. Savage, who's one of our medical directors at Genève, talks about it really well, really understanding the concept of responsive desire, which is the primary desire we feel, especially after menopause, when we've lost that spontaneous desire of
Right.
ovulation. And understanding that in responsive desire, arousal precedes desire.
Mm-hmm.
You need to be able to be aroused. And
You
so
have
there are
to
a
be
lot of great strategies for that. So I usually start with menopausal hormone therapy, cognitive behavioral therapy. And by that, I mean, I have you start working on techniques. I have you get A Tired Woman's Guide to Passionate Sex by Dr. Lori Mintz. Great book, tons of wonderful descriptions of what might be blocking as well as solutions. Come As You Are by Dr. Emily Nagoski. I say we have to do this work first.
right.
And once you've done this work and done the relationship work and gotten your sleep in control and we've solved your vaginal dryness, then we can talk about whether you need testosterone as a boost to sort
Right.
of get you back in the habit. And when I talk to patients, I tell them, we're not prescribing testosterone for the rest of your life. We're going to use this for 6 to 12 months. And we're going to help you get back into a intimacy habit that you can
Yes.
continue from there.
Yes. It has to be a habit for sure.
Mm-hmm.
Which is hard, right? Because talking to people at the peak of their responsibilities, stresses,
Mm-hmm.
um, life goals, everything. So that can be very hard.
It totally
Um,
can.
what do you think about back to the bioidenticals? What do you
Mm-hmm.
think the safety of bioidenticals bioidenticals compared to our traditional menopausal hormone therapy?
So, and by when you're asking, are you talking about the safety of like estradiol and micronized progesterone versus CEE and Provera?
Yes. Yeah.
Okay, because of course this is not a medical term.
Right.
Um, I think there's a lot we don't know. I'll be honest.
Yeah.
When we talk about the risks and benefits of hormone therapy, we talk from studies that used CEE and MPA. Those are our biggest studies. So if you go all the way back to like the Framingham studies and such, where they first detected that women had a cardiovascular benefit from being on hormone therapy, they were using CEE and MPA or CEE. Then in the WHI, all the data that we quote, even in its reinterpretations, CEE and MPA. We don't have nearly as much data on E2 and micronized progesterone. And when we're using it, we need to think about how does it differ in how it behaves?
Mhm.
Estradiol is probably the active ingredient in conjugated equine
Right.
estrogens for most women. However, there's some hint that while transdermal estradiol may be safer from a clot perspective, it may have less cardiovascular benefit than taking an oral CEE or even an oral estradiol. So, why is that? Not entirely sure. It may be levels, it may be how it's processed, but we really haven't investigated it that much. We know that all of them are great, safe, and wonderful for bone. So your bones are going to be happy no matter which estrogen you take. And then we have to think about progesterones, right? So
Right.
micronized progesterone, P4 progesterone is a huge molecule. We have to micronize it to get it through the stomach and into the circulation at any level. And women absolutely, and this is art, not science, we don't study these things, women absolutely absorb it differently.
Mm-hmm.
So I always tell my patients, I'm adjusting micronized progesterone all the time to bleeding because some
Right.
people will do great on a 0.075 patch and 100 of progesterone and never
Yes.
have bleeding and not grow any lining. And others are on a 0.25 and 100 and they're growing lining. And I think there's an absorption component. We
I
also
think
have
there's also
many receptors that we don't
right, there's
understand.
a receptor component that people
Yeah.
express different receptors differently.
So I am not a hard and fast, oh my God, it must be micronized progesterone or nothing
Right.
person. If someone is not doing well on micronized progesterone, I move to Provera or Agestin. Like there are other great progestins out there that work really well. I think there's a myth that micronized progesterone doesn't increase the breast cancer risk, and so we should only use that. That's not entirely true. If you look at the E3N study, this is a great study out of France. So the E3N study, basically France downloads the entirety of their menopausal population and whatever they're taking every 5 years and looks at risk benefit based on what their prescriptions are. And so observational study, which sometimes we consider not as helpful. But on the other hand, as an epidemiologist, I like to think that this is how women are actually using these medications. So it
Right.
gives us insight into that. And what they've shown is that if you look at Provera, Agestin, Mirena IUD even, and that's a whole separate session we're going to have now, in the first 5 years, you pick up a very slight bump in breast cancer risk in people using those progestogens. It's, on the order of what we saw in the WHI, one additional case in 1,000 woman years or less. With micronized progesterone, in the first 5 years, we don't see that bump in E3N. But after 5 years, we do see that bump. So it's not a perfect progesterone. It's not completely getting rid of the breast cancer risk. Maybe it's a little safer, especially in someone you think may not be using it very long. But I don't think that it's so much safer that I have to bend over backwards to keep somebody on it if it's not working for their bleeding or protecting their
Right.
uterine lining, because I'd much rather not give them endometrial cancer.
Yeah, and I think, the other thing to think about is we largely think of progestogens as non-thrombogenic, but actually they can have varying effects on clot risk. And so while obviously we try to avoid depo, medroxyprogesterone acetate in postmenopause for sure, but it also can be highly, as I say to my patients, clotty. Like that it can be much more thrombogenic than other progestogens. But then I think the other thing people don't realize is also that norethindrone acetate can be as well. And actually more so than depo. And so when you're considering what you're going to switch to, taking into consideration the baseline venous thromboembolism risk of your patient as well, and being clear about that as you're prescribing too.
And you may not know the answer to this. This question just came into my head, so bear with me if this is a bit too in the weeds. Do we know if the data on the thrombogenicity of DMPA and norethindrone acetate are completely regardless of the estrogens associated? Because I know we have data from Nextstellis that, because we have all that old data, we had a lot of worry about drospirenone in combination with ethinyl estradiol being slightly more thrombogenic than other OCPs. But with Nextstellis, we're not seeing that. So there's something about the interaction. Do you know if the interaction matters here?
The study that kind of cited these was really looking at them as progestin-only methods.
Okay, good.
Regardless of the estrogen used, that the odds ratio increased with these. We did not see an increase in odds ratio of venous thromboembolism when using micronized progesterone. When using, we wouldn't use this, but using the Nexplanon, etonogestrel, norethindrone,
Right.
or levonorgestrel IUD.
Okay. Well, that's really good to know, because we do have to think about those things. And we're balancing so many things when we're making these prescriptions, right? The other thing I think we should talk about with the progesterone is, does it have associated benefits? How do these behave in the body when we're prescribing them to patients? A lot of patients have heard that progesterone is going to be the solution to their sleep problems.
Right.
And it definitely can help.
I think it can help, but not for everyone universally. And
again, those pesky receptors that are different in different people.
Exactly. And, there are studies that show that just controlling vasomotor symptoms for people is enough to actually help with sleep too. But I certainly have patients that are like, I have to take it right before bed or I get way too sleepy.
Yeah.
So again, the receptors matter. I almost, I've been thinking a lot that I think in the next 20 years, maybe there will be tests that can test for receptors. Now, I don't even know how they could know what part of the body has which ones,
right.
But I think there could be a future in that receptor specific. We're not anywhere close to that yet.
No, we're not. No. And I think it'll end up being genetic testing to understand the preponderance of which receptor types we all have, because there are many progesterone receptors, many estrogen receptors. It's why I tell patients, everybody, every woman has a unique perimenopause and menopause, and every woman will respond uniquely to the hormone therapy that I give her. So,
Right.
sometimes it's just a matter of trying and trying again. And I've had patients, who with micronized progesterone have the opposite of every effect we're expecting. Like I talk a
Right.
lot about progesterone being somewhat of a soothing hormone for us. It tends to be soothing in the brain. But especially those patients who have PMDD,
Yeah.
not necessarily. I've had it
Right.
make depression tremendously worse or anxiety tremendously worse. So you just have to listen to the patient, and there are no hard and fast rules.
Exactly. And, we know that progesterone has an effect on gut motility. So I certainly have patients that start to experience severe GI symptoms afterwards. And we have to talk about pro gut motility measures so that they can take it and still be comfortable and not be constipated or have reflux all the time.
Yeah, no, absolutely. It definitely can loosen some of those sphincters. I remember that from being not hugely pregnant, but having massive reflux because of the
Yeah.
elevated progesterone levels.
Right. Exactly. Exactly.
So lots of things it can and can't do. I am looking at my list of things that I wanted to make sure we cover.
Sounds like we
Let's see. I think that's pretty much the list of upfront topics we wanted to cover. So what I'm going to do next, Ghazaleh, is actually look at our chat and
Yep.
see what sort of questions have popped up. And I'm going to ask anybody who's in the discussion right now, please put your questions into the chat. I would love to answer them and have that guide us down other pathways.
Yeah,
This is
that's
a
a good
very good question. How do we know if a pharmacy is reliable? Uh,
question.
oof, we don't, is
We don't.
the short answer. So there's actually a great John Oliver piece, if you like John Oliver, and he actually looks at how are compound pharmacies regulated. And the answer is there are like four inspectors in the entire country. So they probably get inspected about once every 4 to 5 years. And that's it. They can compound anything into anything that they want to. There's nobody looking over their shoulder. So I don't know that you can know that a compound pharmacy is reliable. That's not to say I haven't used compound pharmacies. So I
Right.
spent a long time as a vulvovaginal specialist, and sometimes we had to compound things to use on the vulva or vagina that you just can't get in a form that doesn't have alcohol or, something that would be very harmful there.
Right. Right.
But you have to think about when using a compound pharmacy, you have to think about, well, what are the downstream effects or risks of compounding this particular medication? So, for example, compound vaginal Valium. When I would talk to my patients about that who had severe pelvic floor disorders, I would say, you're getting systemic Valium. I just don't know how much. So until you understand that, I don't want you driving, all those things. So you just have to think about what's the risk of doing that.
Yeah. And, they are supposed to be within, I think what most of us probably don't understand is that every single pill you get doesn't always have the exact same amount of drug in it, but
Mhm.
the FDA regulates what the range can be, and that those are
Mhm.
quality tested, there are assays done to make sure, and that those things actually don't happen in compounding pharmacies.
Right.
Um, so that quality regulation, quality control is not universal.
Yeah. And there's actually a great article on the North American Menopause or the Menopause Society. Sorry. I still call it NAMS. There's a great article you can access on their website called The Hormone Hoax That Thousands Fall For. And it was
Mm,
actually an investigative journalist who got 7 separate vaginal estradiol prescriptions and sent them off to 7 separate compounding pharmacies, got them back, and then had them lab tested. And they had 7 different doses in them. So, same prescription to each pharmacy, 7 different products were sent back that were very, very, she said, the primarily they didn't have nearly as much as was prescribed. So a lot of them had like 10% of the actual dosing, but one had like 300%. So this is, we just don't know the quality, and we can't know the quality, and we don't have a way to test for it.
Yeah, I think there was a study in the early 2000s that kind of did something similar. And what they found, they didn't test a lot, but they found that largely that all of them had the drug in it, but the amount,
Right.
the concentration was widely variable, and the quality of the drug itself was widely variable.
And the other thing we have to think about is that the amount you get day to day may change, because once they're mixing this into a new base, you don't know how
Right.
it's distributed.
Right.
There are just so many concerns for a product that we don't need to compound, right?
Don't need to.
Because we have it available in FDA regulated forms, lots of them covered. In fact, I love to mention that Divigel now has a generic as well. So if like someone has a adhesive reaction, go to Divigel. There's just so many things that we can do with the FDA regulated medications. And then another question, how often do we check testosterone levels, and what range are we aiming for?
I don't check testosterone levels.
Well, I don't check them in
Right.
random women.
Right.
Because a really important thing that a lot of people don't know is that the free and total testosterone available at the lab is only valid at male levels. So that test does not pick up female levels reliably. So you could get 0 one day and 50 the next, and it's the same blood sample.
Right.
I do test when I'm using testosterone therapy. And I do it in the following pattern. I test before I start to make sure they're not already too high, and I'm not adding into a system that is too high, because lots of people have hyperandrogen syndromes or PCOS, things like that. I then test at 3 and 6 months while they're using the product to make sure I'm not exceeding normal female range, which in my lab is 50. I think it's 50 nanograms per deciliter. But your lab should tell you the range. Be cautious. There are certain labs recommended by the pellet companies, and we'll get to pellets next.
Yes.
Recommended by the pellet companies that have raised the upper limit of normal female to 150. So just keep an eye on that. And then I test usually once somebody is stable and using a stable dose, I'll test annually just to make sure we're not exceeding. But I don't usually keep people on that long. So
Right. Exactly.
it's rare I get to annual testing. And I'm using the free and total testosterone because what I know about it is it's not all that valid at female levels, but it is valid at male levels. So if they're exceeding female levels, I'm going to pick it up.
Right.
And it's a much cheaper test. You can test female levels of testosterone with liquid chromatography, but it's a very expensive test and often not covered. So I only say that if I really, really need it for some reason, which is like once in a blue moon.
And your free and total are going to vary depending on if the estrogen they're using is transdermal or oral, because it is going to affect the amount of steroid hormone binding globulin that they are going to have circulating. So that's why it's so important to be testing both.
Yeah, that's very true. And there's a huge fad in social media about testing sex hormone binding globulin as well. I don't typically test it except very rarely if I need to pick out what's going on with hormones or understand like why somebody's not getting a response. But that's not a routine test either.
Right.
So someone said, please address pellets.
Pellets.
So let's start talking pellets. So what are pellets?
They're these little, they look metallic, but are they metal?
No, so I went to a conference where I told the organizers I would not be back because they let one of the pellet companies exhibit, but they were handing out little like stress cushions, and they're little tiny balls of like oily, waxy thing that yeah.
I've only seen them like on the website, and I was like, are those metal? That's weird. But they're little balls of different hormones, and they are proprietary.
They're compounded.
Compounded. There's a little inserter device to insert them with. And I think this is just always one of the like huge red flags for me. You have to pay the company to be trained to insert them, which seems suspicious.
Yeah.
And then they have, I don't know what estrogen they have in them.
Estradiol.
They have estradiol. They have
theoretically
testosterone.
They don't make a progesterone.
They don't. Okay. And then
No.
they take a progesterone in a different way.
Mm-hmm.
And then it has something else in them?
They may have another pellet. I've only ever seen the estrogen and
Okay.
testosterone ones.
Yeah.
Yeah, and these are very much a these companies outsource compounding to multiple different pharmacies. So the companies that retail them don't even do the compounding.
Oh, I didn't even
And that's
realize.
a really important point because I don't know if many of you know, the FDA actually sent a letter to BioTE, which is one of the major retailers of these, that said, you have had 4,200 adverse events reported and you have not sent those on to the FDA. And BioTE's response was, well, we don't make the product, so it's not our job. And those
Huh.
adverse events included endometrial cancers, prostate cancers, because these are placed in men as well, all sorts of cancers. And they just, put them in a drawer. So this is the company you're dealing with if you're going down this pathway. The other thing about pellets is they're cash pay.
Yes, they're not covered.
They're not covered. And as I tell my patients who've been on pellets, I can give you exactly the same hormones covered by your insurance.
Yeah.
And I'll know how much you're getting, and I'll know we're in a safe range. So I don't know what the benefit of the pellet is.
Well, and you
People,
can stop them when you want to stop them,
right?
whereas when a pellet is placed under your skin, you have to wait
You
until
can't
the
remove
pellet's
it. Yeah.
right.
You can't remove it. And the company says they last for 3 months. That is totally and completely false. I have seen very high levels at 9 and 12 months
Yes.
and
Yeah, I
people
have.
have been getting pellets. Um, there is no safety here.
Yeah.
And
They don't.
I've had many patients come and say, well, my doctor only uses the lowest dose and they do it really safely. I've had doctors talk to me, oh, I do it safely. My patients love them. But there is no way you can be perfectly safe here.
Right.
Um,
You know how much they cost? That's one of the questions here
Oh,
too.
how much do they cost? So I've seen them anywhere from $300 to $700 an insertion per pellet. So often they'll put in estrogen and testosterone, so you're paying twice that. Sort of depends on your region. It's entirely priced based on how much the doctor wants to make. I mean, I think they buy them from BioTE for about $100 a pellet. And then they're also covering their training, which they paid for.
They had to pay for. And just
Um,
you don't have to pay for training to put in a Nexplanon or to put it
no,
in. The manufacturer provides training because they want you to do it right. And probably the FDA requires it.
yes, it does. Having trained residents in that.
Right, exactly.
So I've seen them in varying costs. Sometimes they escalate the cost depending on how much they're putting in. Like the higher dose ones, they might charge more for. Um, the testing can cost money depending on where they send you and what lab they use, because they do a lot of testing to tell you that they're adjusting based on testing. But realistically, in my experience, you're generally over the recommended levels in
Yes.
estrogen and testosterone with any pellet. So I'm not sure what they're testing for and how they're adjusting. Although I have seen some of the recommendations from one of these companies that say you should aim for a testosterone in the 150 to 300 range, which is a male level.
I get a receding hairline. And that's what I see when patients
Yeah.
come to see me, is they're like, I just keep losing my hair. I can't
Uh-huh.
fall asleep. And I'm like, I'm so sorry you saw someone for hair loss and they gave you something that causes hair loss.
Yeah. So it's just, and the last question in that thread is how do we counsel patients about why they're bad? I think we've given you a lot on that front.
Yeah. I
But
think
I think the biggest thing that resonates with patients is I say, you don't need a pellet. I can give you the exact same medication from the pharmacy and we can adjust it to make you feel good.
right.
I think sometimes we get caught up in a cycle. Like when you first put a testosterone pellet in, especially if you're aiming for like 150, 200, you're gonna feel spectacular for a little while.
You're gonna be lifting stuff.
Yeah, it doesn't last. That's
Right.
why they tend to be dosed up because you need more and more to get that feeling again. But, and I'm saying this to a group of other providers. I don't necessarily say this to patients, but there are a lot of things that make you feel spectacular that we do not prescribe, like cocaine
Right.
and opiates.
Right.
you know, my goal in treating women in menopause is to make them feel like themselves and make them
Right.
feel healthy and good, not spectacular. Like, you know, that's not really the goal.
Yeah. And I think
So
it
I'm
is a
gonna go
balance
ahead.
because, uh, I never want someone to feel foolish. I don't want to
Mm-mm.
denigrate the care that they got. And so I do dance that dance of like, well,
Hmm.
it's something I would do. Here are the reasons I don't recommend this. Um,
Yeah.
rather than, I know, and I know the question wasn't meant this way, but rather than
Mhm.
like, these are awful and terrible and bad, because then the
Yeah.
person feels a lot of shame around it too when they didn't
Yeah.
even.
And I think how we talk to patients is very different than how we talk to our colleagues. And I think that's really important because patients don't know, right? They've been recommended a course of action and they've probably been recommended it by someone who thinks they're doing good.
Right.
Because what
Yeah.
I do see a lot of is a lot of the people doing pellets really don't have a basis in menopausal hormone therapy, don't have a basis in menopausal care. They've been to a session that said this is the best way to do it. It's totally safe. You know, these companies produce their own literature that says it's totally safe, which is at odds with the literature that is peer reviewed that says it's not. And, you know, they want to do good for their patients. They're not doing this to be bad doctors or nurse practitioners or PAs or what, but they just, I tend to say to patients, I'm coming at this with a different lens. And that lens is years of menopause experience. And I want you to hear what I have to say, but ultimately the choice is yours.
Exactly. Yeah.
I'm going to throw one at you. Is 100 milligrams of micronized progesterone enough for a 0.05 E2 patch?
Yes, it is.
Most of the time.
Most of the time. I think we talked about this, but I titrate to bleeding. So
Yeah.
if the person is having spotting, then I'm going to go up to 200. I often will use higher than 100 in perimenopause. If someone really doesn't want to use birth control or has a medical contraindication to ethinyl estradiol, but would likely still be safe on estradiol, then after, counseling, risk benefit,
Hmm.
shared decision making, then I will start sometimes even at a 200 because I know they have heavy periods, and might go up from there even too. But 100 is enough as long as they're not bleeding.
Right. The caveat to that is, again, we all have different receptors. Some people just that's not enough. The other
Right.
thing is it can change. So someone in the chat said, I've had patients on it for years where it was fine and now it's not working.
Yeah.
I don't know if it's a manufacturing difference, although there are generics, so there could always be some manufacturing difference. Our gut flora strongly
Right.
impacts how we absorb micronized progesterone. So progesterone, like I said, huge molecule. It's micronized to sort of get past the stomach and into the duodenum and be absorbed there. But, in some patients, I don't think it does that as well. And for some patients, I can never find a dose of micronized progesterone that they're getting enough to manage bleeding. And then we change progestins.
Yeah. Yeah. And it's possible it could be what they eat at the same time as it that is affecting absorption.
Hmm.
I don't know. I don't know. But yeah, it is
Yeah.
different for different people. So,
And the GI
um,
side effect thing, again, different for different people. Some people are really sensitive to it and others really don't have any GI side effects. Same with sleep. Some people, it makes them incredibly sleepy. They have to take it at dinner time because if they take it at bedtime, they'll still be so sleepy in the morning they can't function. And, we just have to, we do a little try and try again. I said this on a webinar yesterday. I don't call it trial and error because it's not an error, it's just a difference.
right. Yeah. And
Oh,
for sure.
great question about vaginal micronized progesterone. The vagina absorbs micronized progesterone great. The vagina is wonderful at absorbing it. So if you put a 100 milligram oral pill into the vagina, you're getting a huge dose. So if you look at the vaginal progesterone, it's 37.5 milligrams, I think, the one that's used for fertility.
Mhm.
Um, the one used for fertility, however, is not a great long-term solution because it gets irritating over time. It's got a slight alcohol base.
Yeah.
I will tell you guys, and it's between you, me, and the wall. I happen to know there is in development something along the lines of a femring that also contains micronized progesterone. So exciting future hormone options. But yeah, we don't have a good menopausal hormone therapy dosed vaginal product. I do have some patients who put the micronized tab in their vagina. You know, they're probably getting a lot higher dose, but if they tolerate it, I'm not that worried about it.
Yeah, I have a few patients doing it, and largely because they have severe GI side effects or mood side effects that
Mm-hmm.
seems to be okay when they do it vaginally. Art, not science. If that
Yeah.
is what is
I mean,
that
it's
is
peanut oil. It's probably fine, so it's not going to hurt your vagina.
right.
Um, here's a question for you. Someone asks, what's your go-to progesterone after micronized progestin?
It depends on where they are at. So if they are kind of pre-perimenopausal or I mean, I love an IUD. So that's really like where
Yeah.
I'm right, complex family planning here. So if they can get an IUD in person, even with my telemedicine patients, I'll chat with them about that as an option.
Mm-hmm.
Um, Especially if you could still get it covered on your insurance at this point, then you'll at least have it for the next 8 years. Um, eh, Potentially okay all 8 years for that. We don't actually really have data
We don't
on
know
any
that yet.
protection, but at least 5.
Mm-hmm.
It'd be good for that. Um, I have used norethindrone acetate before when we've had micronized progesterone on back order.
Mm-hmm.
Um,
I often, so in my perimenopausal patients, especially if contraception is still a concern or they have a terrible bleeding pattern, Slind. I
yeah,
use
Slind.
Slind and add a
Okay.
patch to it.
Yeah,
Um, but in general, in my postmenopausal patients, I tend to offer them Provera. We have 50 years of data
yeah,
I can quote on it. I feel comfortable dosing it because it's what we've always used. And I know it's a strong progestin and will protect their uterine lining.
yeah.
And I know people are scared of it because of the WHI, but it's got no different a profile in terms of breast cancer risk than any of these other progestogens. So, and that's what I tell them. It's no worse. So, and I can reliably tell you that I know how this works.
Right, right.
Well, I am not seeing any more questions. Ghazaleh, this has been a wonderful discussion. Thank you so much for
Yeah,
joining me for this.
of course. Thank you for having me.
And everyone, please go on our website. I'm sure Britt can put it the page to sign up for next month. And Britt, you're gonna have to remind me because I'm having a menopausal moment. What next month's topic is?
I am going there right now. I too am having a menopausal moment. Hang on, I'm navigating there to get you the link. We just have a new section on our website dedicated to these clinical webinars. So here, I'm copying it right now. I'm going to drop it in. I will include that also in the follow-up email, so you can bookmark that. We don't have the functionality right now for people to go and sign up for every one of our upcoming webinars. We're working on that.
That's
I
a
know you're
Teams thing.
yeah, I know you're all busy and want to do that, and we're hoping to get a solution for you. All right, so the next one is alternatives to HRT, risks, benefits, and how to choose.
That's right. I get to talk with my colleague and friend, Dr. Ashley Fuller. Um, she and I both have participated in some of the clinical trials around some of these newer medications for hot flashes. For like Bioza and some of the stuff coming from Bayer. So we're going to talk about what are all of our non-hormonal options, medication-wise. We'll address a little bit of the alternative stuff as well, and what data do we have? How do they work? Who are good candidates? You know, what are some of the myths or concerns you may have heard? I'm going to ask her a lot about the new recommendations from the FDA on Bioza and liver function tests and why that happened. It'll be a great discussion. So a great way to sort of review all these medications that are now being offered and risks and benefits because every medication has them.
Good session. Looking forward to that.
All right. Thank you everybody for joining us today. And thank you for all of you watching after the fact. I hope this was helpful. Take care.